Welcome to today's deep dive. I am just so glad you are joining us today. We have a really compelling stack of sources on the table, and honestly, I think this conversation is going to fundamentally change the way you view a lot of common human behaviors.
Yeah, thanks for having me. I have to say, the documentation we are looking at today is just incredibly eye-opening.
It really is. So for you listening, we are looking specifically at the clinical guidelines for body-focused repetitive behaviors in Georgia schools, alongside a broader K-12 mental health framework from an organization called MentalSpace School.
Right, and it just challenges everything we, colloquially think we know about willpower, about habits, and really about how we support young people who are in this very quiet, very hidden kind of crisis.
Exactly. And so our mission today is to completely dismantle the myth of the quote-unquote bad habit. We are going to explore what these behaviors actually are, why the conventional wisdom of just, snapping out of it fails so completely.
Oh, it totally fails.
Right. And how schools are now stepping up to provide critical specialized interventions. But before we get into all the clinical terminology, I want you to imagine something.
Mm-hmm.
Imagine just for a second that you are dealing with this overwhelming, almost magnetic urge to do something that visibly damages your own body.
Yeah.
You don't want to do it. You feel this intense, crushing shame about it every single time it happens. But the urge is like a physical pressure building up inside you until you finally just cave.
It's a compulsion.
Yes, exactly. And then imagine finally gathering the courage to show someone the physical damage, to actually ask for help, and having every well-meaning adult in your life look at you and casually say, well, just stop it.
It is just an entirely dismissive response. And the tragedy there is that it completely misses the reality of what that person is actually experiencing on a neurological level.
Right?
It assumes the behavior is a conscious choice,
Yeah.
when the reality is, it's far more complex.
Okay, let's unpack this because we need to get some terminology straight right out of the gate. We are talking about something the medical community calls BFRBs.
Yeah, that stands for body-focused repetitive behaviors. So this is an umbrella term, and the clinical guidelines we are examining focus heavily on two specific conditions under this umbrella.
Okay.
The first is trichotillomania, which is hair-pulling disorder, and the second is excoriation disorder, which is skin-picking disorder.
Got it. Now, we should be clear for anyone listening who might, occasionally twirl their hair while reading or pop a pimple, that is not what the source material is talking about, is it?
No, not at all. The clinical threshold here is very explicit. We're talking about recurrent, body-focused behaviors that result in actual physical damage.
Like severe damage.
Yes. For trichotillomania, we are talking about noticeable, undeniable hair loss. The common pulling sites are the scalp, the eyebrows, the eyelashes, and the arms.
Wow, okay.
And for excoriation disorder, the behavior results in real skin lesions, open wounds, and scarring. That's typically on the face, arms, scalp, and hands.
That sounds incredibly painful.
It is. But the defining characteristic, the real thing that separates this from just a quirky habit, is that this physical damage occurs despite repeated, agonizing attempts by the individual to stop.
So the person is actively trying to quit, and their brain just simply overrides them.
Exactly.
The medical reality highlighted in these guidelines is the critical point for me, honestly. These are not bad habits. They are formally recognized in the DSM-5.
And that categorization is a massive paradigm shift. I mean, the DSM-5, which is essentially the psychiatric master rule book used by clinicians globally, it doesn't put these behaviors in a category about poor self-control.
Right. It's not about willpower.
No, they literally have their own place in the OCD-related disorders chapter. It takes BFRBs completely out of the realm of behavioral choice and places them firmly in the realm of clinical pathology.
Using standard talk therapy to fix a BFRB is kind of like trying to fix a hardware issue with a software update.
That's a great way to put it.
Or, to put it another way, casually mislabeling a BFRB as a bad habit is like looking at someone having an asthma attack and telling them to, just breathe better.
Right, yeah.
It's a neurological misfire. The underlying physical wiring is the problem, not a lack of willpower. But here is where I actually want to push back on the sources a little bit, or at least question the data.
Oh, okay. What part?
Well, the guidelines state that the prevalence of trichotillomania is about 1 to 2% of adolescents, and skin picking is similar. And the texts note that it often emerges right around puberty.
Yes, that's correct.
But if this is happening during puberty, Literally the most socially anxious, self-conscious time in a human's life. Isn't that 1 to 2% just the tip of the iceberg? I mean, who is actually going to report this?
What's fascinating here is how the onset timing perfectly creates this absolute storm of concealment. You are entirely right to question the prevalence data.
I knew it.
Yeah, the sources explicitly state that these conditions are dramatically underdiagnosed. Puberty is a time when fitting in, establishing a social identity, and physical appearance are just paramount.
Right, hormonal shifts are already creating all this emotional volatility.
Exactly.
So it is the absolute worst possible time to develop a neurological condition that leaves visible physical marks on your face or your scalp.
Precisely. And this is where we enter what the clinical guidelines describe as the cycle of shame.
The cycle of shame.
Right. Because the results of the behavior are physically visible: bald patches, missing eyelashes, open sores. The immediate, overwhelming reaction of the adolescent is to hide it at all costs. They do not want to be seen.
And the lengths they go to, according to these guidelines, are just staggering.
Truly.
We are talking about teenagers wearing full wigs to high school every single day, using incredibly heavy, thick, theatrical-grade makeup to cover lesions on their face and arms, wearing long sleeves and heavy hoodies all the time, even when the weather is like 90 degrees and humid. Imagine how exhausted you would feel as a teenager trying to maintain this daily physical and psychological cover-up.
Oh, it becomes a full-time job on top of navigating the already complex world of being a student.
Yeah.
And it creates a self-perpetuating barrier to treatment. The physical damage causes immense psychological distress. That distress manifests as profound shame.
And that shame is the wall.
Exactly. That shame prevents the adolescent from ever raising their hand and saying to a parent or a doctor, "I need help." They are terrified of being judged as weird or unhygienic, or, of being told they are doing this to themselves on purpose.
Which brings us back to that 1 to 2% statistic. If every student suffering from this is utilizing military-grade stealth to hide it from their parents, their teachers, and their peers, of course, the documented numbers are artificially low.
Right, they have to be.
The real number of kids walking the halls with this burden has to be significantly higher.
The architecture of this condition is built entirely on secrecy. And the tragedy outlined in the sources is that even when a teenager is brave enough to ask for help,
Which takes incredible courage.
it really does. Or, more commonly, when the physical evidence becomes impossible to hide and a parent finally notices the missing eyelashes, the traditional healthcare system often completely fails them.
Because they get the wrong advice. The adults deploy the just stop it method, or they get sent to a general counselor who tries to treat the BFRB like a generic stress issue.
Exactly. The evidence base presented in these guidelines is uncompromising on this point. Generic approaches simply do not work for BFRBs.
Here's where it gets really interesting, because the source material points out that even standard cognitive behavioral therapy CBT, which is, widely considered the gold standard for so many mental health issues like depression and generalized anxiety, it is largely ineffective for this specific problem.
It is a critical distinction for clinicians, educators, and parents to understand. Standard CBT focuses on identifying and changing negative thought patterns.
Like, how did that make you feel?
Right. The therapist might ask, "What were you thinking about when you started picking your skin?" But BFRBs are often driven by an underlying physiological tension or a sensory urge, not necessarily a conscious negative thought.
Interesting.
A student might be pulling their hair while entirely relaxed watching television simply because their fingers are seeking a specific sensory feedback from the hair follicle. You cannot simply talk therapy your way out of a neurological urge.
So if talking about their feelings doesn't stop the picking or the pulling, what do therapists actually do? Do they physically restrain them?
Not quite physical restraint, but you are hovering near the underlying concept of the actual treatment.
Oh, really?
Yeah. The guidelines detail highly specific evidence-based treatments that move away from generic talk therapy. We are looking primarily at habit reversal training, or HRT,
Yeah.
and comprehensive behavioral treatment, known as COMB.
Okay, let's break those down. How does habit reversal training actually work in practice?
HRT involves meticulously tracking the specific sensory, environmental, and emotional triggers that precede the behavior, and then implementing what is called a competing response.
A competing response.
Right. So if a student's trigger is feeling a specific physical tension in their fingers right before pulling hair, a competing response might be instructing them to instantly clench their fists
Oh, I see.
or press their hands flat against their desk for 60 seconds whenever that urge hits.
So you are creating a physical roadblock so the brain's urge can pass without the damage actually occurring.
Exactly that. You are physically occupying the hands, so the destructive action cannot be completed, while the brain rides out the neurological waves of the urge.
Wow, that makes so much sense.
And the COMB model, comprehensive behavioral treatment, expands on this by mapping out the student's entire environment.
Are they pulling in front of the mirror? Let's cover the mirror or change the lighting.
Oh, that's clever.
Are they picking while doing math homework? Let's give them a sensory fidget toy specifically during math. It sounds incredibly targeted. It's not about asking, how does that make you feel? It's about asking, where are your hands right now and what can we put in them instead?
Exactly.
The sources also mention that pharmacology can play a role alongside these behavioral therapies. They mention SSRIs and a supplement called N-acetylcysteine.
Yes, and the mechanisms there are just fascinating. SSRIs, or selective serotonin reuptake inhibitors, are sometimes used to help regulate serotonin, which can assist if there is co-occurring anxiety or depression exacerbating the BFRB.
Right, because the shame causes anxiety.
Exactly. But N-acetylcysteine is particularly interesting. It is an over-the-counter amino acid supplement, but neurologically, it modulates glutamate in the brain.
Glutamate is a neurotransmitter, right? How does that connect to pulling hair or picking skin?
Good question. Glutamate is the brain's main excitatory neurotransmitter, and it is heavily tied to the brain's habit and reward pathways. So by modulating glutamate levels, N-acetylcysteine can sometimes help dull the intensity of that overwhelming magnetic urge to engage in the repetitive behavior.
So you have a potential biochemical buffer, but the core intervention still has to be that specialized behavioral training.
Without a doubt.
Which means a specialty referral to a BFRB-trained therapist is absolutely critical. A general counselor simply isn't equipped to map out competing responses and environmental blockers.
If we connect this to the bigger picture, you can see why relying on generic mental health advice for a specialized DSM-5 condition does such a massive disservice to the patient. It actually prolongs their suffering.
That is so true.
Think about the psychological impact. When a teen finally overcomes their intense shame, asks for help, gets generic talk therapy, and still can't stop pulling their hair, what happens?
Oh, man. They assume they are a lost cause. They think the therapy didn't work, my brain is fundamentally broken, and it really is just my fault.
Yes.
That is a devastating cycle. It reinforces the exact shame they were trying to escape in the first place.
It drives them further into hiding. So the clinical reality is that this requires highly specialized trained therapists who really understand HRT and COMB.
But we've already established a major logistical nightmare here. These kids are hiding in plain sight, entirely consumed by shame. And even if they do get a diagnosis, the wait list for specialized child psychiatrists or specialized behavioral therapists,
They could be brutal.
yeah, they can be 6 months to a year long in many areas. So how do we actually get these specialized experts in front of the kids who need them today?
You have to fundamentally change the delivery mechanism. If the wait lists at the private clinics are a year long, you stop making the kids come to the clinic. You bring the clinic to the kids.
I love that.
You bring the specialized care directly to where they are already spending the vast majority of their waking hours, school. And this introduces the broader K-12 mental health framework we are examining today, specifically looking at MentalSpace School in Georgia.
Yes, let's talk about them.
They are pioneering a school-based revolution in mental health care access.
I want to spend some time on MentalSpace School because their model completely flips the traditional healthcare access paradigm on its head. According to the documents, they provide a comprehensive suite of clinical services directly integrated into Georgia K-12 schools.
Yes.
Deeply integrated.
We are talking same-day teletherapy, dedicated, consistent therapist teams assigned to specific schools so the kids actually build a rapport with them over time.
Right, they aren't just talking to a stranger every week.
Exactly. They offer crisis intervention, suicide and violence prevention, and they even extend their services to offer staff wellness programs and family counseling.
It is a total ecosystem approach. Historically, schools have relied on a siloed school counselor. But one counselor cannot possibly manage the severe specialized clinical needs, like BFRBs, severe trauma, or acute OCD for a population of 1,000 students. It's just not possible. Under the MentalSpace framework, you have a dedicated, licensed clinical team woven into the school's daily fabric. And a crucial detail highlighted in the guidelines is the makeup of these therapists.
Oh, yeah.
They are culturally diverse and culturally competent.
Which is absolutely essential when you are trying to break down entrenched barriers of shame and stigma. A student needs to look at the screen and feel understood by the person on the other side.
100%.
The cultural context of hair, for example, varies wildly, and a therapist needs to understand that nuance when treating trichotillomania.
Absolutely. The teletherapy aspect itself is also a game changer for accessibility.
Mm.
It completely removes the need for a parent to leave work, pull the kid out of school, and drive across town to a clinic. But it is worth noting that there is also a massive compliance and urgency angle driving this integration in Georgia right now.
Right, the new law.
Yes. The source material notes that MentalSpace provides the infrastructure for schools to meet the HB 268 compliance deadline, which is approaching in July 2026.
So the state is actually mandating enhanced mental health support, and school districts are scrambling to figure out how to provide clinical-level care legally and safely. Delivering actual health care in an educational setting sounds like a bureaucratic minefield.
Oh, it requires navigating an absolute labyrinth of privacy laws, which MentalSpace manages by ensuring everything is fully compliant on two fronts.
Okay, what are those?
First, they have to protect the student's medical privacy, which is governed by HISIA, shielding their medical secrets and treatment plans. Simultaneously, they have to be FERPA compliant, guarding the student's academic record and educational data.
It is a heavy lift to build that infrastructure. But the most staggering part of this whole framework, at least to me, is the financial accessibility.
The insurance piece.
Yes. When anyone hears the phrase highly specialized clinical teletherapy, the immediate assumption is that it is going to cost a fortune. It sounds like a luxury service for wealthy school districts.
Right.
But the sources lay out the insurance reality, and it is incredible. For Medicaid patients, the out-of-pocket cost is $0.
Dropping the out-of-pocket cost to zero for Medicaid patients removes the single largest barrier to mental health care for the most vulnerable populations.
And they don't snap at Medicaid either. They haven't just partnered with the standard corporate insurance giants. The sources say they accept, BCBS, Cigna, Aetna, UHC.
Humana, Peach State, Amira Group, all of them.
Right, CareSource too. They have essentially built a financial net designed to catch every single student regardless of their family's socioeconomic status.
And when you synthesize all of this, when you remove the logistical barriers by putting the therapy in the school, and you remove the financial barriers by navigating the insurance landscape, and you apply highly specialized, protocol-driven care to hidden conditions like BFRBs.
Yeah.
The outcomes speak for themselves. The data from MentalSpace's framework shows an 89% improved attendance rate among participating students.
Wow. Just think about the human impact of that number. Kids who were chronically skipping school because they were too exhausted to apply their makeup,
Yeah.
or because they couldn't successfully cover up their hair loss or their skin lesions that morning, and now they're finally going back to class. They are re-engaging with their lives.
Because they are finally getting the specific neurological and behavioral treatment they need, rather than being told to just try harder.
Exactly.
The data also shows a 92% reduced anxiety rate among participants and an 85% family satisfaction rate. I mean, parents are getting their kids back.
So what does this all mean? When you step back and look at the whole picture, from the hidden, crushing shame of a teenager with trichotillomania pulling their hair in secret, to the robust, integrated infrastructure of MentalSpace School, it means we are finally catching up to the science.
We really are.
We are removing the logistical and financial barriers to specialized care. We are taking conditions that have historically been shrouded in absolute secrecy, and we are meeting these kids exactly where they are, with the exact therapeutic tools they need. No more generic advice, no more blame.
It represents a monumental shift in how we approach student well-being. It is a shift from punishment to pathology, and really from isolation to integration.
To wrap up today's deep dive, I want to reiterate the core truth we've uncovered in these sources. If you take away anything from our conversation today, let it be this. Body-focused repetitive behaviors like trichotillomania and excoriation disorder are deeply misunderstood, specialized OCD-related conditions. They are neurological urges, not habits. But with the right evidence-based protocols like HRT and COMB, and with accessible school-based frameworks like MentalSpace tearing down the financial walls, teenagers do not have to spend their most formative years hiding in the shadows.
And it leaves us with an incredibly profound question to consider as we look to the future of our communities.
Oh, I like a good question. Let's hear it.
If specialized telehealth platforms can successfully deliver highly stigmatized, complex clinical treatments directly to a student's desk, yielding 89% better attendance and 92% lower anxiety, How long will it be until we view schools not just as educational institutions, but as the primary healthcare hubs of our future communities?
That is a fascinating thought to mull over, and it really reframes what a school is capable of being. Thank you so much for joining us on this deep dive today. Keep questioning those simple explanations for complex human behaviors. And remember, the next time you are tempted to tell someone to just stop it, there is always more beneath the surface.